Parathyroid carcinoma is a rare cause of primary hyperparathyroidism which presents with clinical manifestation of severe hypercalcemia. It was first described by Swiss surgeon Fritz de Courbin in 1904. Around 90% of parathyroid carcinoma are functional and may present with palpable neck mass which invades locally. Skeletal and renal complications are commonly present at presentation. Surgery remains the only effective treatment for primary tumors with en bloc resection of the parathyroid carcinoma. Parathyroid carcinoma occurs equally in males and female, unlike parathyroid adenoma, which are more common in female. Parathyroid carcinoma mostly in the found between 4th to 5th decade, while the parathyroid adenoma is common between the 5th to 6th decade. Parathyroid carcinoma generally runs slow but progressive course. Less than 8% of patients have lymph node or distant metastasis at initial presentation. The mean time to recurrence is generally between 2 to 5 years of age, and it takes locoregional and cervical lymph node involvement about 30%, liver metastasis about 10%, and bone or brain deposit less than 1%. Failure of treatment can result in death from hypercalcemic related end organ damage within 14 months. In general, however, parathyroid carcinoma tend to have a relatively indolent course because of tumors having low malignant potential, with 5-year survival around 86% and 10-year survival about 60%. A significant proportion of patients, 25%, will be diagnosed with parathyroid carcinoma after initial surgical treatment following review of histopathology or after developing metastatic disease. Patients with parathyroid carcinoma are typically younger than those with the benign cause of hyperparathyroidism. Parathyroid carcinoma occur equally in both gender. Since 90% of parathyroid carcinoma are functioning tumor, most manifest with symptoms similar to benign hyperparathyroidism, namely weakness, fatigue, anxiety, depression, bone pain, renal stones, abdominal pain, peptic ulcer disease, and pancreatitis. However, bone disease and renal involvement are far more common in the parathyroid carcinoma, occurring about 80 to 90% of patients with parathyroid carcinoma, and presence of both is strongly predictive of malignancy. Bone disease include bone pain, osteopenia, osteoporosis, pathological fracture, osteitis fibrosa cystica, salt and pepper skull, and subperiosteal bone resorption. Renal involvement include ureteric calculi, nephrocalcinosis, renal impairment, acute pancreatitis with peptic ulceration, and hypercalcemic crisis occur in about 12 to 18% of patients with parathyroid carcinoma. These symptoms usually occur before local invasion by the tumor. Serum calcium and parathyroid hormone are elevated in parathyroid carcinoma, but the average calcium is much higher in parathyroid carcinoma than the benign cause of hyperparathyroidism. Most patients with parathyroid adenoma have serum calcium level within 1 mg per deciliter above the upper limit of the normal. Patients with parathyroid carcinoma have serum level in excess of 14 mg per deciliter and serum parathyroid hormone level 10 to 15 fold greater than the normal range, and parathyroid hormone level 10 times the upper limit of normal carries a positive predictive value of about 81% chances of parathyroid carcinoma. Imaging of parathyroid carcinoma differs from the parathyroid adenoma because it emphasizes on the detection of locoregional tumor infiltration and distant metastasis. Neck ultrasound is non-invasive and sensitive study for detection of enlarged parathyroid glands. Parathyroid carcinoma are typically larger than 15 mm, hypoechoic lobulated irregular lesion seen on the ultrasonography, and ultrasound has high accuracy in detecting the parathyroid lesion if it is more than 1 centimeter or larger. Ultrasound can also be used to guide FNAC biopsy for the parathyroid carcinoma or neck lymphadenopathy. But FNA of the primary lesion should be avoided to prevent disruption of primary tumor. FNA is not useful in distinguish between the benign and malignant parathyroid tissue. Technetium 99 system AB scintigraphy is useful for localizing primary, recurrent, and metastatic disease. It also helps to confirm the ultrasonographic localization of the tumor. The radio-labeled isotope had particular affinity for parathyroid mitochondria. It cannot, however, discriminate between the benign and malignant disease. System AB has high sensitivity about 80% and positive predictive value about 91% and continue to be the most useful imaging modality in benign and malignant causes of hyperparathyroidism. Four-dimensional computed tomography is increasingly used for parathyroid localization in hyperparathyroidism, particularly when ultrasound system AB imaging is negative or indeterminate. It has a sensitivity and specificity about 82 and 92% respectively for localization of parathyroid adenoma. Parathyroid glands have unique angiographic and perfusion characteristics, including blood flow into the intra-arterial contrast used for distinguish abnormal parathyroid tissue. 4D CT scan use non-contrast imaging to differentiate thyroid from parathyroid tissue as well as early post-contrast phase to determine a hypervascular gland and delayed post-contrast scan to detect altered enhancement or abnormal contrast retention. This 4D CT scan having higher exposure of the radiation and it's only useful in the recurrent or indeterminate cases of parathyroid carcinoma. In cases of recurrence, we can also use PET scan and MRI to detect and localization of the mediastinal tumor. Surgical resection is the main therapeutic modality for the parathyroid carcinoma, even in the presence of metastatic disease. Treatment for hypercalcemia, correction of renal dysfunction is often necessary prior for surgical intervention. Hydration with saline, correction of electrolyte imbalance, diuretics and biphosphonate are useful to optimize the patient condition prior to the surgical resection or en bloc resection is necessary in cases of parathyroid carcinoma. Parathyroid carcinoma can be difficult to diagnose intraoperatively but usually appears as large, firm, grey-white mass with adherent to adjacent structure and often greater than 3 cm in size, while parathyroid adenoma are smaller, softer and reddish brown to tan in color. En bloc resection involves carefully removing the parathyroid lesion and resecting all adherent tissue with grossly clear margin. This will typically involve ipsilateral thyroid lobectomy and adjacent level 6 lobe dissection. This approach frequently requires auto-transplantation of the ipsilateral parathyroid gland where it appears microscopically normal as well as sometimes required cervical thymectomy. It is important not to rupture the capsule as this increases the risk of shedding and recurrences. Parathyroid carcinoma can also involve the overlying strep muscle, trachea, esophagus and recurrent laryngeal nerve. In order to provide the best chance of cure, these structures may require en bloc resection. Recurrent laryngeal nerve involvement is suspected preoperatively if patient has hoarse voice and warrant resection in cases where function is lost due to tumor infiltration or where it is involved circumferentially by the malignancy. Sacrifice of normally functioning nerve is generally not recommended. Shantz and Kesselman developed a set of criteria for the histopathological diagnosis of the parathyroid carcinoma in 1973. These include presence of fibrous capsule or fibrous trabeculae, involvement with presence of mitotic figure, and capsule and vascular invasion. That later added with the presence of adjacent skeletal muscle invasion by the tumor. So these are the definitive criteria for the parathyroid carcinoma. In 2004, WHO defined the parathyroid lesion displaying vascular invasion, perineural space invasion, capsular penetration with growth into the adjacent tissue or metastasis are the cases of parathyroid carcinoma. HRPT2 germline DNA testing should be considered for patients presenting with apparently sporadic parathyroid carcinoma. It is unclear whether genetic testing should be offered to the relatives, but monitoring serum calcium levels offer a simple alternative to definitive diagnosis of these parathyroid carcinoma and risk of the relative.